Hi, for those of you who don't know me, my name is Michelle Wozniak. I'm the nurse manager on Good Sam 5. It's a medical stroke unit in the Good Samaritan building. I'm also a student at Grand Canyon University, where I am currently obtaining my master's in nursing. We are as I said, a 20-bed medical stroke unit. We have 36 staff members plus myself. Over the past 6 months, patient census has decreased from an average of 18 patients per day to an average of 12 to 13 patients per day. We flex a minimum of 2 staff members every day. Every one of my staff members has had at least one day of pay where they are flexed. 21 of my staff members have less than 12 hours of paid time off in their bank. This has led to many staff taking time off without pay. Staff morale and engagement is at an all-time low. When staff is flexed, although the staffing ratios will stay the same with 1 RN to every 6 patients, the ancillary staff is no longer able to assist in the care of the patients. My floor is not alone in this problem. The census throughout the hospital has dropped from an average of 98% daily to an average of 70%. Flex staff reports show that on average 200 hours of flex time are used every 2 weeks on every single nursing unit throughout the hospital. Inpatient revenue in the last quarter has been down by $1 million below budget. Nursing satisfaction and engagement scores have dropped significantly throughout the hospital, with many staff seeking to leave the organization entirely. There are many reasons for the decrease in census: a mild flu season, a focus on reducing the length of stay, also a focus on reducing readmissions, and the shifting of healthcare in general from a focus on inpatient to a focus on prevention. All of these reasons point to the patient numbers not returning. To counteract the decrease in numbers, I propose a closure of 20 beds and a staffing reduction. The current med-surg unit on Good Sam 5 has had low quality scores for quite a while. HCAHPS have been below state and national average for the past year in every category. Their quality boards have been in the red for the entire fiscal year of 2015. Productivity has consistently run over by 2.5 FTEs every pay for the past 6 months. On the other hand, the dashboard from E6 has been all green in all categories except for those that relate to HCAHPS, in cleanliness and satisfaction with the organization for the past 2 years. This is despite its location as the only inpatient unit in the E building, as well as being on the oldest unit in the entire hospital, a unit that had not been renovated since its opening in the 1960s. I propose a merger of the med-surg units on Good Sam 5 and Good Sam 6. The staff that is in good standing from Good Sam 5 can take positions available throughout the hospital or on the increased staffing on Good Sam 6. A workforce reduction of 12 staff members should occur at this time. First, those employees who are not in good standing, who are employed on Good Sam 5, and then the others who are not given positions throughout the organization. Once Good Sam 5 has closed, The medical stroke floor from E6, including all staff members and the current patient population, should move to the Good Sam 5th floor. Capping the new floor on Good Sam 5 at 20 patients with 20 beds will eliminate 20 beds from the hospital census, increasing the average daily census on all of the medical surgical floors. This plan will increase nursing satisfaction as well as balance the budget and ultimately increase patient satisfaction. Planning meetings for the move should include a representative from all involved stakeholders, including human resources, finance, materials management, information systems, pharmacy, nursing administration, the nurse managers and directors from Good Sam 5, 6, and E6, dietary, security, facilities, quality, patient placement, the director of nursing practice, and the chief nursing officer. In the planning meetings, we will establish a timeline for the closures and for the move. Frequent, honest communication with the staff is essential to maintain their cooperation. The first round of communication should come from the chief nursing officer at the clinical coordinator meeting, as well as through nurse managers at the staff meetings. This communication should explain the current state and that the leaders are working on a solution and have proposed a closure of a unit and redistribution of staff. After the first planning meeting, where a rough draft of the timeline is established, the first communication needs to be with the staff members from Good Sam 5 and Good Sam 6. Immediately afterwards, communications need to go out to the rest of the nursing staff and to the hospital in general. As each of the goals in the timeline are met, another communication from the chief nursing officer must go out to the staff involved with the next goal. Updates on the status of the timeline should be shared during the weekly huddles, as well as by the nurse managers in their staff meetings and as they speak impromptu to the staff members on their floor. Communications with the neurologist as well as with the physicians are essential to ensure that they are aware that the stroke unit has moved and we are maintaining the same patient population as what was available on E6. On Good Samaritan 6, a new productivity standard will need to be developed by finance. The new staff will need oriented to the floor as well as to the expectations of their new nurse manager. The E6 staff will require an orientation to their new floor as well. The effectiveness of the plan will be evaluated on a continual basis, bi-weekly with productivity reports, with the bi-weekly flex time reports to determine how many nurses continue to be flexed after the closures. Also with an employee satisfaction pulse survey that can be given every 2 months to determine how engaged and how satisfied the nurses are with the current system and with the current amount of beds. Financial reports are run every 2 weeks, also monthly. And these can also be used to evaluate the effectiveness of the closures. If the overall hospital census maintains above 90% following these closures, then the plan would be considered to be effective. And we would have also with a balanced budget, the plan would consider to be effective. If anyone has any questions, please feel free to ask me. I will be available. Thank you for listening.